Kia ora, I'm Holly from the Ovarian Cancer Foundation New Zealand, and today we are talking advocacy. Today's session will be presented by our CEO and lived experience facilitation lead, Liz Pennington. If you've got questions during the session, please wiggle your mouse or tap your screen and you can send them through during the Q&A feature, but we'll address them all at the end, and we might also open things up at the end as well to allow some extra questions. The session will be recorded and it will be available on our website in the next week or so you'll be able to watch this back or share it with others. There are some hard-hitting facts, stories, and systemic shortcomings shared in this report, so today's session may be heavy. If you require any support, please reach out or feel free to pause today's session and know that you can watch it back later. Now I'm going to kick this off by sharing a short video from the launch of the State of Ovarian Cancer report at Parliament. Apologies, just finding the right screen.
My name is Erin Bassett, and in May 2020, my own world turned upside down with the diagnosis of stage 4 low-grade serous ovarian cancer at just 35. But appointment after appointment, my symptoms were dismissed.
You are the people behind the data, the faces that inform the facts, the reason we are here today. And behind every graph, every number, every statistic is a woman. We're here today to seek the progress that is so desperately needed.
So there's real opportunity here to empower women with clear, accessible information to support informed decisions. Our goal was to create a report that was readable and accessible, and that didn't shy away from what could often be tough reading. So a heartfelt thank you again for coming together today to educate, to raise awareness, to support those affected, and ultimately to help save lives.
Excellent. Now we will hand over to Liz and she will talk through today's presentation.
Thanks so much, Holly. Kia ora, everybody. Awesome to have you here joining us today. So tēnā koutou katoa, ngā mihi nui kia koutou katoa. We're really pleased to have this opportunity to reconnect. It's been 3 months since the launch in February, and there's been lots of activity since then and more planned. So we really wanted to touch base with you today and have an opportunity to talk through about what those next steps might look like for us, but also for you. We're really keen to advance the actions identified in the report together with you. So we've got a small presentation here for you. What we're going to do in the beginning is just do a bit of a recap of the report and its contents, and then move into the important part of today, which is about actions and the way in which we can help move forward in terms of transforming outcomes for women. So again, thank you so much for joining us. So beginning by acknowledging the late Ruby Smith and acknowledging her contribution to this report. You can see her image here on the front and within it, and we acknowledge all the women that were very much part of bringing this report to life, really, and sharing their stories really courageously, because some of this was tough, as the word Holly used at the beginning there. Some of it was tough. It was, was difficult, and so we're hugely grateful to our community for their contribution to it. So we presented the report, that was in February, and the report began and ended with women's voices and the voices of the people that cared about them most, their family members. Women shared a variety of conversations with us, and we've just selected 3 of those here. I know what I was feeling. I got a definite impression that my narrative was being dismissed. So that sense of not being listened to or not being heard was the experience of some women. Another woman, I was lucky and caught it at stage 2, thanks to the doctor who sent me for a CA125 blood test after 10 days from my very first symptoms. So here again, we see that variability in women's experience. Then the third one, I didn't know that discussing cancer would be part of my diagnosis based on the symptoms I was presenting. I would have felt embarrassed to even mention cancer, as if I was overreacting. So we began with women's voices, and in the report there you will see that real kind of leaning in and holding up of the experience from the community within the report. The stats, we did a bit of a deep dive into those. Now, when you're looking at the report, if you haven't had an opportunity yet to do so, you'll see it being layered up. You'll see some detail throughout the report, then you'll see QR codes within it that you can deep dive into more detail if you want to. So what we've got here is just some high-level stats that just remind us of the importance of the need for change and a focus on ovarian cancer. So 306 women diagnosed every year, 207 women dying, 30% dying within 1 year of diagnosis, and a 5-year survival rate of 43%. Now, I would want to acknowledge there that that is an improvement on the previous data that we were using, which showed survival rate at 5 years at 36.6. So that's a gain, and we're really pleased to see that. What concerns us also is that a number of women are being diagnosed in ED or emergency department, and you can see that stat there. It's high, 48% of women. That's where they're finding out that they actually have ovarian cancer. We did 3 surveys last year, one of GPs, one of women with ovarian cancer, and one with the general public, with 500 members of the public. And what we found there was that 80% of Kiwis didn't know what the symptoms of ovarian cancer were. And 1 in 5 women had to wait over a year from their first doctor's visit to getting diagnosed. So what the report was able to do when we went out and used those 3 surveys that we conducted was really evidence some of what we were hearing from you. So we'll just, thanks, Holly. So why does early diagnosis matter? It matters because we don't currently have a screening tool for ovarian cancer. It matters because not, as we heard when we looked at the survey results there, as we could read, that many of the symptoms just aren't known or they're missed. Women often experience delays in their diagnosis, and we know that if we can get diagnosis earlier, it's really going to improve the outcomes for women. Again, a quote from one woman around her experience of going to the doctor every month for almost 2 years. So if we've got symptoms, we've got delayed recognition, we've got emergency diagnosis, then often that's going to translate to outcomes that aren't as good as we would want. Now, you and I both know that our experience currently in the primary care space is that often there are delays in appointment times and being able to even schedule an appointment, or for some people to enrol in a practice. So all of these things, layer upon layer, have impacts that we're seeing, and you of course are seeing as well. So what were the key themes in the report? That the general public generally thought that cervical screening tested also for ovarian cancer, which it does not. 64% thought cervical screening detected ovarian cancer, and 24% were unsure. So when we put those 2 together, obviously, 64 and 24 together, we're looking there at about 88%. 85% of New Zealanders had heard of ovarian cancer, but only 20% could identify warning signs and symptoms. So that again helped us identify we needed to do some work there. And 70% of women diagnosed knew of ovarian cancer, but only 10% knew any of the symptoms. So in the photo there, we've got Minister Nicola Grigg, so just to acknowledge her, and she spoke and gave an address at the report, and we were really grateful to have her support and participation in the launch event.
Liz, sorry, we've just had just getting a little bit of an echo from your microphone. I just wonder if you could perhaps try it a tiny bit further away from yourself.
Okay.
Let's see how that goes. Thank you so much.
Yeah, no, thanks, Holly. So next slide, please give us some feedback as to whether that's less echoey. That would be helpful, thank you. So the next slide, we've got Erin here, and Erin Bassett is an ovarian cancer advocate and was part of the event, sharing her own story. So what were the key themes that were the barriers to diagnosis? So when we asked GPs, access to ultrasound was challenging, with 61% saying it was difficult. So that was identified by GPs as a primary issue in the delay to diagnosis. So that's important for us to note in terms of actions for advocacy. Prior to diagnosis, 75% of women's symptoms were attributed to other causes. So IBS, meaning irritable bowel syndrome, or general menopause. 1 in 5 women had to wait over a year from their first doctor's visit to actually getting a diagnosis. So during that time, many women were attending visits regularly and still wanting to find or waiting to find out what was actually wrong. So again, further themes, and in this picture we've got Alicia Didsbury, and Alicia is works at the University of Auckland. She works in the area of research. She actually has a PhD in cancer research and serves on our board as a trustee and leads our MedSci advisory committee. So what are the key themes? So we had Alicia's image included here because this is all about data, and there are data gaps, and data, of course, is crucially important to a researcher. So there is currently no ovarian cancer register. So the data that's collected at the moment is collected when we're diagnosed. So say if I'm diagnosed in an emergency department, the data will be recorded around Liz Pennington, diagnosed with perhaps stage 3, high-grade serous, and I'm referencing that because I'm older, so it might be more likely that that was my experience. So that gets recorded. We then also have recording of mortality data when people pass away around the reasons for that. So again, we'd have data recorded there. But that piece in between, from that point of diagnosis through the whole treatment journey, that isn't recorded in a central place that's retrievable. So that lack of register is something that we see as critically important. Researchers like Alicia need access to that data, and access to the register is going to be able to be hugely helpful for them. And clinicians who are doing the work and the women themselves benefit from a treatment journey being clearly recorded and the data from that being accessible. Because again, going back to the example of me, we can look and see what has worked well for other women like Liz with high grade, stage 3, what is the data telling us about that? So again, register, hugely, hugely important, and one of the things that we are very keen to see an investment in. So just a reminder about the work that we're doing, because today is very much part about leaning into this space. I often refer to it as we talk about the 4 pillars, or PO. I often talk about it as the 4 legs of the table. I'm not quite sure why, but there you go. I do, but I guess it's around that idea that each is connected to the other. So the awareness work, we can understand how important that is, particularly in the absence of a screening tool. So we know that we can save lives, actually, by leaning into that awareness work. Advocacy, sessions like this one today, sessions like that launch in Parliament where we give visibility and we gather people together to know and understand women's experience and to call for change. Support, so that's in reference to our support services, and as many of you will know, we offer online support groups. We offer one-on-one counselling, Orongoa Māori, for women with lived experience. We also support rehabilitation with funded sessions. We're also soon to be starting services for families in terms of online support groups. So all of those things are an integral part of the whole in terms of the things that we do. We also fundraise for research. So research is a key part because we know that is where we can transform outcomes and really work towards that overarching goal, which is to find a cure for this thing. You know, it is to find an answer, to save lives, and to achieve the sort of results that we can see achieved with investment in other cancers. That's what we're wanting here as well. So each of those four all connected together and all super important. So the 8 actions. So it's fine to talk about a report and look at the data, share the information, but what's really important is, so what do we do? It can feel overwhelming, too big, too much. Where do you start? But what we were clearly able to do, having undertaken that work, was distill from that 8 actions that would shift the dial. And I'm just going to talk through those, and then we're going to kick into the most important part, which is, so what are we going to do to get movement in these areas, or across all 8 really. So the first is reduce that incidence of diagnosis in emergency department. None of us head to emergency departments as our primary choice of places to go. They're busy places. They're filled with injured and unwell people. And so people go to ED when they have a really pressing need and they need to be seen urgently. So we know that being diagnosed in ED will often mean that at the same time as a woman finds out what's happening for her, she might also receive a prognosis that not only is this cancer, but that it is a life-limiting cancer. Now, that's not the same for all, but we know that that emergency diagnosis piece is absolutely critical to address. As we said here, why? Because it's nearly half. Now, you might say to me, well, look, Liz, in terms of ovarian cancer, maybe with this disease, it is always about half, but that's not the case. If we look across to our cousins on the other side of the Tasman and across to Australia, their rate of ED diagnosis is significantly less than ours. They record it sort of state by state, but it's anywhere from 21 to 28%. So that's significantly less. So we might look at that and say, well, why is that? You know, what inherently is happening in there that's leading to that difference? The pathways in Australia, the clinical pathways are different to here. A woman who presents to their GP and is symptomatic, that is, she has signs and symptoms of ovarian cancer, is sent or referred at that first appointment for a CA125 blood test and an ultrasound. That is not the case here. It is the case for some women, but not for many. So that's a key difference. So we know that the rate of incidence could and should be lower. So what do we want to do about that? What are we thinking the answers are? We are suggesting that to add the ovarian cancer symptoms education into the National Cervical Screening Program is a really simple and obvious thing to do. That a woman knows when she's got a cervical screening result, or she's involved in the cervical screening program, that the test that she has had and the results that she has are indicative of the status of her cervix, but not of her ovaries and for other gynecological cancers. And we think women would want to know that. We think that there's an opportunity for women to be told that, to be given that information at that time in those conversations, and that in itself would save lives. We also want GPs to be able to send symptomatic women straight through for those 2 tests that we just talked about. CA125 is just simply a blood test, and ultrasound access, obviously, and we're talking about that through the public system. We know in our talking with women that many were indicating that they'd been encouraged to go through the private system because it would be faster to gain access. So clearly access to ultrasound is an issue for us, and it's an important one. Secondly, we need to address the data gaps and make accurate real-time data more accessible. Why? Because we need to know what's working. We need to be able to identify and improve. Women need to be able to look at that treatment pathway. Researchers like Alicia need to be able to get that data that they need to help inform the research that they choose to do. So we need and want an ovarian cancer register. We know that that will make a significant difference. Next slide, Holly, if we can. So thank you. So identifying people at higher genetic risk. So we know that this is a small subset of total women diagnosed, but it's still an important figure there, 10 to 15% being hereditary. So we want to see women being able to access BRCA testing. We want a familial cancer registry to track and intervene, because what that does is enable us to take action ahead of people being diagnosed, not wait for a diagnosis and then for things to happen. And we want legislation just like that which has been passed in Australia in the last couple of months against genetic discrimination by insurance companies, because we see screening, the work toward screening and the commitment to try and identify screening, as well as this work being hugely important because it's a public health issue. So we want women to feel that they can go and have the genetic testing and it's not going to be disadvantaging them in terms of insurance. So in the absence currently of a screening tool, we certainly see that there's a need to be doing this. Addressing the gynae-oncology specialist shortages, we know we do not have sufficient for the population that we have of 5 million. If we look at the current numbers, around 7 to 8, as they were at the report, and that might have moved a bit since, I'm not sure, but it's a lot less than what the best practice guidelines would indicate, which would be 15 to 16 for our population. And so investing in that workforce and supporting recruitment's key. And of course also we want to support the people that are doing the work. We want to have concern for their well-being and their ability to carry, the patient caseloads that they are. So we're thoughtful about support for those doing the work now, as well as the need to bring more in to work alongside them, and for women to have the coverage that they need to be able to give them access as close to home as possible. It's all part of that package of things there. Prioritising ovarian cancer trials. Many women will be looking for cancer clinical trials as part of their ovarian cancer journey. They are a critical part of treatment, and that is part of how we find out future, this is part of how the work is done toward future treatment options, is through clinical trials. Currently in New Zealand, there are 5 clinical trials. They have criteria that you have to meet to be able to join those. And that if we, again, go across the Tasman and think about what is available in Australia, there are 44 clinical trials. So when we're looking at that difference, yes, you might say to me, Liz, some of that's population-based, and that would be true, but it's also a very significant difference, and it is part of the reason why women are choosing to go to Australia, is to get access to those clinical trials. Back to the discussion on research again, and we talked a little bit about this in terms of the need for data, didn't we? And again here, we need to see investment in research. We know that the level of funding here is not as much as it needs to be. We want to see actually a research strategy. So rather than small piecemeal actions being taken or one-off investments in research, we actually want to see an overarching ovarian cancer research strategy and a framework so that all of us that are working in this space can contribute to something that's cohesive and is going to deliver good outcomes for women. We want access to a national ovarian cancer biobank so that we can safely collect and store tumour samples from women so that they're easy to access and be utilised by researchers with consent, obviously. So those things are important. Currently, in the year ahead, our fundraising activities, some of our fundraising activities last year were targeted very much around research. So thank you to those who supported us in the October event last year and also in the Long Lunch event in Auckland. Each of those contributed direct dollars to our research investment. And this year we're investing in 2 $80,000 grants. We've invested in 2 overseas travel grants, allowing researchers to travel overseas and work with other ovarian cancer researchers and bring that back home. And we also invested in 3 professional development grants. So all of these things, again, are those things that are going to transform outcomes for women and shift that dial. It's a range of things that need to happen here. And we need women with lived experience involved in service design, policy and research. It's pretty fundamental, isn't it? This idea that there are conversations happening about us, but they should include us, or they shouldn't be without us. So we're looking for that participation. Within the foundation itself, we have a lived experience advisory group comprising women with lived experience of ovarian cancer. We also have separately a family lived experience advisory group, also again reviewing and advising and supporting the board with decisions to be made around the work of the foundation, our strategic goals and plans going forward. So that lived experience voice, that peer-to-peer kind of piece, is a really hugely important part of the work. And we are certainly calling on the fact that women with lived experience should be part of any service design and investment decisions going forward. It shouldn't be an afterthought that the community is consulted on, because women have something to say. And we need to advocate for their voice to be heard in the planning, not only in the evaluation of services. People want to be involved in co-design, actually, because they have a strong sense of what they need. And then we want to improve medicine's access and investment, and this will be something that will already probably resonate with many of you. We know that we have issues around the level of investment that we've got. So why? Because the length of time to approve new treatments is too long. Some have taken 12 years in terms of sitting there on the options to investment list before they've actually been funded. And we know that there are issues around that for many women. So the funding through PharmAct needs to be significantly increased. And that's something we feel really strongly about. If we think about our health investment currently, if we think of health in a bucket, and we imagine that bucket being filled, about 4.9% of that total bucket is spent on medicines in New Zealand. So 4.9% of that big full bucket, about just under 5%. If we compare that with other countries in the OECD, and remember the OECD's been around since about the time I was born, which is a wee while ago, the 1960s. Yay, the 1960s. That's when it was set up. It's got about 38 countries in it. And the average in the OECD for investment in medicines of total health budget spend in that bucket is 13.3%. So let's just think about those two figures again. 4.9% Aotearoa New Zealand and 13.3% the average in the OECD countries. So we're not just a little short, we're well short. So that does translate to mean that people are missing out, and they're missing out on things that can impact their health outcomes, their access to clinical trials, and also things that could deliver real value to them in their journey with ovarian cancer. So those are the actions. Those are the 8 areas of focus. What we're looking at wanting to do now, and it's a really important time to be doing this in an election year, of course, is to be thinking about, okay, so how it can be better. But not only that, but what can we all do? What action can we take? What's possible? We can't all hop on planes and head to Wellington. But we do have local MPs. We do have a voice. We do still have a postal service, albeit a reduced one. And we do have needs across rural New Zealand. You know, that's a significant issue in terms of reach and in terms of people being able to access services as well. So we know that it is possible for it to be better. And what we've done within this report is not only identify the evidence and listen in to the voices of women, of GPs and health practitioners and of the New Zealand public, but we've recorded and detailed up what needs to change. So we actually have the answers. So we want to see lived experience voices informing service design and evaluation. We want women to be able to participate directly. We want research. We want funded research for more treatment and early detection, because this is all about diagnosis early, because we know that that shifts the dial and makes massive improvements to the outcomes for women. We want better access to treatment and clinical trials. We don't think that 5 is sufficient or acceptable as a number. access to real-time data that can inform treatment, we could get that through the register, right? So if that information's being inputted in the moment, then people can go in and look at that. Other clinicians who are providing care to me or to you can get in there and look at that information and use that to help support the decisions that are being made or suggested to you. We want stronger wraparound support, and we really, really can see that all of this can lead to a future where there is an improvement to survival rates whilst we still remain clearly wedded to our desire to find a cure and do what we can to do that. Next slide, please, Holly. So how can you be part of it? So this is just an image of some of you that might even be on the call today. I'm not sure, but from those gathered. So you can write a letter to an MP. We've written up a template letter that you could utilise if you want to. We know that it's good if letters are personalised and include your own information and that sort of thing. So you certainly don't have to use the template letter. It's just really an opportunity for you to, if it's helpful. But getting those letters written, you know, when an MP's getting a number of letters come across the desk all talking about a particular issue, they listen. And they particularly listen in an election year when they're very thoughtful around gauging the feel and the vibe of the community. You can request a meeting with an MP. We've written up some talking points for you if you wanted to use them. You certainly don't have to. But we thought in terms of feeling confident to do that, it can feel quite a big thing if you haven't done that before. To have some notes you could refer to would be actually pretty good. So there's some talking points there that we've pulled together. You can request meetings in person, but also remember you can request virtual meetings, because if you live somewhere like I do, traffic can be hard, parking can be difficult, so there's nothing wrong with requesting a virtual meeting. So, you know, that's just as effective as an option, or even a phone call actually is also a good option. You can share a copy of the report with someone. So you can rock up to the neighbour next door. You don't even have to go far from home. The neighbour is a good place to start. You know, your own family is a great place to start and say, did you know this stuff? Here we are in 2026 and we still have these statistics and the situation for ovarian cancer. It needs to be better. So what can we do? There's a really strong sense that it's time, you know, it's really time for this to change. We've written, you know, rather than the big report, we've written the one-page report summary. So it's kind of 2 sides of A4. And wait on, I'm just going to lean down and grab one here beside me. So we've got done a sort of 1 page so you can see some of those stats I was talking about. And then on the back, the 8 asks. So you might even want some of those, because they're a great way of just succinctly gathering up the key points. So we've got heaps of those printed off, and they're part of the advocacy packs we've pulled together too. You can put posts on social media. I know heaps of you will be on Facebook. You might have a LinkedIn account, which is where I will tend to put bits and pieces. You might be on Instagram. So if you're able to support by putting this information out across your social media channels, then what we do is just amplify the voices, because you'll have networks, right? So you might have, I don't know how many followers. So when you're sharing and then you're inviting your network in turn to share, it's kind of like the pebble in the pond, right? It gets wider and wider. And so that's a real practical thing that you can do. Just sitting at home with your phone in your hand, you know, use your social media platforms. You can share with people you know the calls for action, and you can request an advocacy pack from us. So we've made them up. They're all ready to go. I'm hoping that you're going to want to have one, and in it you're going to get that short form of the report I just showed you. You're going to get some awareness cards and information and brochures, and it is also the talking points for meetings and a template letter. So you'll be able to kind of have a look at that, have that resource at your fingertips to pretty much do whatever you feel works for you. Now, it might be that you don't need it and you don't necessarily want it because you're going to do some things yourself and you've got some ideas about that. And that's great. What we're wanting to do is just really facilitate and enable the advocacy work. And so these advocacy resources are really there to just support you in raising the issue and giving some visibility to ovarian cancer, particularly now, between now and election year. So engaging with your GP at the moment. So this is again a photo of the board members, and Ali Ludeman on the right there is our patron. And Ali's the mum of Jane, who is our founder, Jane Ludeman, and then our board members. So we've got Ben Russell there beside me, and then Dr. Alicia Didsbury, of course, Linda Leonard, and Malcolm McLeod. And Malcolm is also a member of our family lived experience group. So really important to see that this idea of engagement with MP was the trip to Wellington, but it's also a whole lot of other things that need to happen now. When you're booking, remember, and you're trying to get an appointment, remember it can be really good to look at when Parliament's sitting. So if you're a Wellington-based person, obviously when Parliament is in session, that's the time you want to make your appointment, and you can jump on the Parliamentary Services website and check that out, because there'll be chunks of time when Parliament's not sitting that you're not going to be able to access anybody. It will take usually a couple of weeks to make your appointment. You can do the phone call thing, the email, or the virtual appointment, whatever is going to work for you. You don't need to be too technical about it all, or know all the numbers or the stats. Your experience, if you have lived experience of ovarian cancer or know someone that has, that makes you an expert anyway, right? Because you're going to those appointments with that knowledge and understanding. You're likely to get a short meeting, particularly now as we head up to election, maybe 10-15 minutes. So rather than trying to go in all guns blazing with loads of information, it can be really good to focus in on 2 or 3 key things that you're really wanting to focus on. Remember that your MPs, whilst this can feel a little awkward for some, but remember they're there to serve you. And they're there to also represent all of us, and we're an important part of the community. So it's their job to actually listen. So feel emboldened about that, I think, in terms of asking for those meetings, and feeling good about taking your questions to those meetings. And just finally from me, a quote from Ruby. And this is one of the ones she shared with us for an inclusion in the report, and it feels again a good place to conclude this part of the discussion by again leaning in and listening and honouring the voices of women. So Ruby said to us, "Living with ovarian cancer has given me a deep understanding of how isolating and overwhelming this journey can be. I've seen firsthand that while research is essential, so too is the need for practical, compassionate support that helps women feel seen and guided through every stage. Being part of this group," and Ruby's referencing here the Lived Experience Advisory Group, "is about helping shape that change, bringing real experiences to the table so no woman feels unheard or left behind." So we acknowledge Ruby and her family today. So look, that concludes the actual presentation piece. We're really grateful that you've joined us today. As I've said to you, we've got advocacy packs pulled together. We were really keen in these 2 sessions today for you to be aware and updated on the work that's been done since. We've been knocking on doors, having meetings with ministers, writing letters, putting in parliamentary questions, all of those important things. So that work continues, but we can't do it on our own, and we really need your help. So my encouragement to you is to think about what you might be able to do. And as I said, it might be as simple as sharing with your immediate family, sharing with the neighbour over the fence, maybe with a cup of tea, so you get a chance to chat for a bit. But any of those things will really help amplify that voice, give some visibility to ovarian cancer, and raise levels of awareness. So look, thanks so much for joining us. I'm just going to pass to Holly and see if we've got questions or comments or things that people would like to discuss. We'll cease recording before we do that, but I'll pass back to Holly now. So thanks so much, everybody.
Thanks, Liz. Yes, so just a reminder, if if you're not watching this live and you want to get in touch with any questions, you want the resource packs, or you just need some help getting started, please send us an email at support@ocfnz.org.nz.